Also in medicine, reimbursements are going down. So physicians aren't getting paid as they used to in terms of reimbursement from insurance companies, Medicare, Medicaid. So it's a lot tougher. And people would say, oh, well, you probably are making six figures. But yeah, but the loans were six figures, the interest rates are double digits sometimes, and your salary is not as it was before, as many years ago. So and then you have to catch up.
Everybody. Welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinions, unfiltered, unapologetic, and always with a dose of empowerment. We're here to amplify voices, yours and ours, challenge the status quo, and explore what it truly means to thrive. So let's get into it. I'm Dr. Santoshi Bilakota.
And I'm Dr. Shalom Mokbel.
And today we have a very special guest. We're friends with him outside of this podcast individually. And I've been friends with him for a very long time since we met in training. We have Dr. Wendell Bobb. He's a board certified neurologist, clinical neurophysiologist, and a sleep and medicine specialist. So, Wendell, thank you so much for joining us today. Do you want to introduce a little bit more about yourself to the audience?
Of course. No, thank you so much for having me. And I actually also knew Shayla from before, not as long as Santoshi, but so Wendell Bobb, as Santoshi said. I'm from Trinidad originally. So I grew up there. I did high school there, and then I moved to Grand Cayman, and I worked there for a little while, for about a year. And I then, of course, decided that I was going to do my undergrad in Florida. So I did undergrad, and of course, I don't know, we'll probably get into maybe more of my life journey at some point. But and then now I ended up in DC. So I practice sleep medicine, general neurology, and an aspect of clinical neurophysiology, which some people are familiar with, some people aren't, but essentially the study of the waves of the central nervous system or the peripheral nervous system, and using this to help people who are have neurologic disorders or who need surgical correction of their problems or certain neurological or neurosurgical issues with intraoperative monitoring. So that's sort of a nutshell of what I do.
Wendell was my attending. That's a very funny story. I think during 1 year, he was my attending, great attending. And he inspired me actually to even pursue IOM because I could see him doing IOM, and he diversified between IOM and clinical neurology and sleep. And that was very inspiring for me. So thank you, Wendell.
Oh, wow. I didn't even know that. Well, see, sometimes you interact with, other people, residents or training fellows in training, and you don't really realize that something you do or just the way something that your professional course actually inspires or helps somebody or gives clarity. So that's great. Thanks, Shayla. No, and since that time we've become friends, and there's no sort of power barrier. Not that there is necessarily. Sometimes in training there could be, unfortunately, but I always try to not let that be an issue. But it's great to know the two of you.
But what a small world, because later Santoshi invited me to her wedding, and then I see you there.
I was there.
It was what a nice surprise.
It was a very pleasant surprise, absolutely.
Wendell, what originally inspired you to get into medicine? And do you feel like that motivation has changed over time, or how has your journey been for you?
Yeah, so it's interesting. My recollection of when my interest started in medicine is what my mom would tell me. So she would say, I used to tell people, maybe when I was about 3 years old or something, that I want to put water in a needle and give it to old people to help them walk better. So I guess that was my way of saying, being familiar with the doctor and probably vaccination, thinking that it was just a needle. But so I think I've always had an interest in becoming a physician. I always remember requesting doctor kits, those plastic doctor kits with the plastic stethoscope and the syringe and reflex hammer. And I just enjoyed, being a play doctor when I was younger. So then that, of course, led me, and as I went into high school, I realized that I did like science. It was really cool. There were a lot of things to understand. It helped me understand the world in which I lived. Also in biology, helping me to understand a lot more about the human body. So from there, I then went to Grand Cayman for a year. My family moved from Trinidad, where I grew up, and I worked actually as a dental assistant for about maybe 9 months or so, because I wanted to do something clinical and I wasn't sure exactly, or to get into the field, making sure that I wanted to do medicine. Now, granted, I'm not a dentist, but that was the closest I was able to get at the time, and that was available for me in a clinical setting. So then I moved on to do my undergrad in Florida. So I studied chemistry. Then I actually took a year off because I needed to do the MCAT as well as a couple other prerequisite courses for medical school. So in that year off, I did substitute teaching, and I realized that there was no way I could be a teacher. I wanted to at one point either be a doctor or a teacher, and I realized, okay, there's no way I can be a teacher. I my hats off to teachers because it's a lot of work, and so much of it is just discipline. But anyway, did that. Then I also went back to medical school there in Florida. Did and that's where my interest in neurology happened. I remember everyone's advice. I would get advice from people in the higher years, and their advice was when it came to neuroanatomy, just study really, really hard because it's a tough course. So I didn't really have an interest in neurology before that. So my goal was simply to pass the course and to do well. And when I started learning and I realized, oh, the right side of the brain controls the left side of the body and vice versa. And also that there were a lot of behavioral manifestations of pathologies or things going wrong in the brain. I thought that that was really interesting because a lot of times, if someone has a problem with their pancreas, right, they may have diabetes, and that's socially acceptable. Nobody looks down on them for that. Or if someone has a blocked coronary vessel, they may end up with a heart attack. Nobody cares. But then if there's some problem higher up in the brain, in the frontal lobe or the temporal lobe, that may cause behavioral manifestations or behavioral changes, then a lot of times that becomes sometimes socially taboo and people may not want to talk about it, whether it be mental health or psychosis, things like that. And I found that it's the same pathology or similar pathology, just in a different part of the human body. So my interest in neuroanatomy or neurology peaked at that time. Did a residency in neurology. I moved to Georgia to DC, and I did my residency here in DC. Then during residency, I was rotating in sleep medicine, and I also learned about we knew I knew about sleep apnea before, but I really got into it when I did a rotation, an elective during residency. And I didn't realize how much people didn't know about it. And there was so much more to learn about sleep and sleep disorders and how they not just affect our bodies physically, but how it affects our mental health and as well as so many other issues that sleep apnea is a risk factor, primary risk factor for strokes, for heart attacks. We now know for Alzheimer's disease and the critical role that sleep plays. And I thought this was also fascinating because in medicine we have a culture where we probably, at the time we were doing 30-hour shifts, nonstop shifts. We do 24 hours as we're all used to. And then the next morning you have to actually report without sleep. Then you have to remember everything about every patient you admitted the night before, everything about their case. Why didn't you do that? Well, why didn't you listen to their carotid arteries? I'm like, well, I have like 6 patients to admit plus manage patients on the floor. I'm exhausted. And it was a real paradox that here it is, I'm learning about the importance of sleep for learning and for prevention of medical errors. When we learned that, the someone who is 18 hours sleep deprived, it's similar to having, or let's say 24 hours, it's similar to having a blood alcohol level of higher than the legal limit. Yet we encourage our fellow doctors and the trainees to do this. Granted, some things have changed, but a lot is still the same. So I felt it was important for me to study sleep so that I can primarily educate and treat people about sleep disorders because it's really important. And it's not, the slogans or, we'll sleep when you're dead and, having this feeling that you're invincible and you're strong because you can operate in less sleep. It was very damaging, a very damaging culture. So I wanted to be part of that. And then, of course, I also wanted to be able to know a lot more about seizures and detecting seizures, which is done, as you both know, through EEGs or electroencephalograms. And so those are for people, where we detect the brain waves and things. So that's why I also was interested in that. So I did 2 fellowships. I moved to North Carolina and did 2 fellowships. One was in sleep medicine. The other was in clinical neurophysiology. So, and From there, I ended up moving back to DC at some point, and of course, Sheila mentioned I was one of her attendings at the time, and I am also here now, doing a mixture of sleep medicine, neurology, and neurointraoperative monitoring. And just briefly for the audience members who may not understand know what that is, but during certain brain surgeries or spinal cord surgeries, we detect the brain waves, which allow us to know if there's anything going wrong in the neural pathways, so that we could communicate with the surgeons in real time. So that's sort of where I'm at and how I got from Trinidad to here in DC now.
Amazing journey. So, what was the biggest challenge for you as a physician after you became an attending, and how did you overcome it?
Right. So, well, becoming an attending in itself was a huge challenge. And I think depending on what stage of my career, that the response to that answer would change. But initially, as an attending, that was a huge learning curve. Even though there was still, we did quite a bit of training at, 4 years of medical school, 4 years of residency, 2 years of fellowship. There's nothing that really prepares you for fully practicing on your own, at least on an emotional level, when you realize that, hey, you're it. It stops with you. But it's been many years since that time, and I feel at this point one of my biggest challenges is really getting to that work-life balance, and sometimes knowing boundaries, learning when to say no. Medicine is a very demanding culture as well as specialty, and sometimes you cannot just clock out, clock in, clock out as easily as some other professions. It really requires everything when you're there, all of your willpower, your mind power, and that it can be mentally draining, whether it be through sad news or outcomes that you had very poor outcomes that you may not have had any control over. There's a huge mental toll that goes into our daily lives as physicians. So sometimes a lot of time or many times that spills over, whether it's working 60-hour weeks or even longer, trying to find time for my personal life, for my health, and also ensuring I have adequate sleep as the sleep doctor, because I preach about sleep to everybody, but yet that can be so challenging for me sometimes to wind down as well after a very stressful day, or when I have to take call almost on a weekly basis. I have to stay up much longer than I would recommend my patients stay up. So that's one of my biggest challenges. And part of the my solution to that is really understanding and being aware that this is a problem. Many times in medicine, we hear of being doctors as callings. And I actually heard on one of Dr. Bilicotis Santoshi's uh, prior episodes that, when that term is used, yes, it could be, and for many people, it is a calling. And I believe for me, it is. But that's also used to sometimes abuse the knowledge and the kindness that most physicians have inherently, right? We go into this because we want to ensure people are better. We want to see people get healed, get their problems get fixed, ensure that they live a really well balanced lives. So it's important for me, even though I do believe it's a calling for at least for me, to ensure that there's balance and learning to say no, not just at the job when, you know, if there's things that I can, do for another day to put off for another day, but also sometimes too, it may involve, family members or friends or people close to me. If I know I just really need to sleep, or if, this afternoon I really wanted to go out, but I just need to rest, or if I have a few days off, I just literally may need to stay at home or not do much or not go on a trip or something like that. So it's all about, for me, learning the balance. And I feel that's one of my struggles that I've done a lot better or done better at recently, but I do need to continue to improve on that.
Yeah, Shala and I in our toxicity episodes talk a lot about that term, a calling, because, like
Yes.
you said, it is weaponized sometimes, and not sometimes. I think all the time.
Yeah.
Physicians are altruistic. We want to do good. No one comes into this. Well, maybe some people come into this thinking they're going to make a lot of money, but for the most part, we're ethical individuals. We come in
Yeah.
wanting to help people, and I think that's sometimes kind of thrown in our face, expecting us to do
Absolutely.
more and more and more, but not giving us the tools to achieve that. Like you said,
Right.
We're sleep deprived, over caffeinated. We don't get time off during residency. It's like military training, and none
Yeah,
of us signed up to be soldiers. So
right.
it's pretty awful. And then another thing Shala and I talked about in our toxicity lectures is the later gratification that we get, right? Because
Yeah,
we spend most of our 20s and 30s working for not a lot of money. And then you finally are making a paycheck, which is probably better than what you've seen your whole
right.
life.
Yeah.
However, now you have these loans,
Yep,
and the loans have interest on them. And you're behind. Like all your friends have houses,
yep.
they have these cars, and you're still kind of living like a resident because you have to. So the question I have for you, Wendell, is because we're friends, I know you've managed to be a homeowner, you put a significant amount of dent in your loans, and I think they're mostly paid off at this point. Congratulations. Do you have any advice for current students or residents who are very overwhelmed by the amount of loans that they have? And it's almost like a crisis. I remember when I left or when I graduated, I saw the amount that I owed, and it was shocking because you don't think about this.
Yeah.
It's like monopoly money till you have
Yeah.
to pay it back.
Yeah, loans. Oh my gosh. That I don't know if I want to mention
Nightmare.
exact amount, but definitely in the hundreds of thousands. And then of course we're limited, as you mentioned, in terms of with the amount of hours we spend in residency, it does not pay as it should, and we get a significantly less than people assume that we're getting. It's real. Some people have compared it to low income or working at McDonald's or a fast food restaurant. When you consider the number of hours that we put in residency compared to the salaries, so it's especially if you're living in a higher cost living area, like I did my residency in DC. There's not a whole lot that you can do to save and put towards make a significant dent in loans, but then the interest accrues, particularly for those other loans that are not subsidized. So I remember when, at the time of the pandemic, when volumes went down and a lot of patients, everybody was scrambling to transition to uh, video healthcare, and certain non-urgent cases, neurosurgical cases got postponed. It really hit me that medicine, which we thought was such good job security, that was threatened, and that may not be the case. And I realized I still have to pay my student loans because I my loans were private. So for lower interest rates, people who did have the federal loans or kept the federal loans, that was at a much higher interest rate. But for those who went private, we had to still keep paying our loans despite significant drop in salary. And I just remember feeling the weight of that and the stress of that, and the numbers just getting higher because unless you make significant dents with each payment, especially when it's in the hundreds of thousands, a couple $1,000s a month isn't doing a whole lot. If anything, it's maybe getting the interest. So that's when I took between roughly 2021 to last year just to hunker down, try to, not do much traveling, just keep expenses to a minimum, and really try to get rid of these loans because I just didn't want that to hang over me. Now, a lot of people, I did not necessarily take the advice of many people, which was to invest heavily, invest a lot of that money heavily into other things, and you can use that later to pay off loans. For me personally, it was just important to get that weight off of my head, and it wasn't unreasonable either because some places, like if you want to borrow money for a particular loan, they do take into account debt to income ratio. Now, thankfully for some physicians, they have, or physicians, there's some banks that may not take into account the debt from medical school, so that's helpful. But in other cases, they do, right? Or refinancing and things like that. They definitely look into debt. So that's something I just needed to get down for myself, and I'm very happy that I did. But it's challenging. It's very challenging, and that's something people really need to consider when they want to get into medicine. The amount of loans that's required to get through, unless some people are fortunate enough to have family members or some other way to pay without having to borrow money. But that's a huge issue.
Yeah, I mean, it's very difficult because even those who can afford it, I mean, these days
Mhm.
it's very challenging to afford it because the tuitions are getting higher and higher.
Yeah.
So in the old days, yeah, you see kind of physician families can afford to pay for their kids' medical schools and college, but nowadays it's I mean, it's extremely difficult to do that.
Oh, yeah. And with the cost of living, right? If even just owning a home from 2023 to 2024, 5, where we are now, I mean, the average cost of a home in 2023 was maybe about 230,000, roughly, depending obviously on the where you live. But now the average cost is 400,000, right? This is just from 2 years ago to now, and even from 2020 to 2023, again a significant jump. So also in medicine, reimbursements are going down, so physicians aren't getting paid as they used to in terms of reimbursement from insurance companies, Medicare, Medicaid. So it's a lot tougher, and people would say, oh well, you probably are making six figures. But yeah, but the loans were six figures, the interest rates are double digits sometimes, and your salary is not as it was before, as many years ago. So it's and then you have to catch up. Santoshi, also Dr. Bilakota mentioned earlier about catching up, because we finished training, many of us in our 30s, some of us late 30s, when many of our friends and family members, they've started making their full salaries at a much younger age. So, I'm not complaining. I'm certainly feel fortunate to be in the position that I am in, but there are challenges for sure that need to be considered.
When I started,
Mhm.
going down the medicine pathway, because we were like 18, 19 making these
Right.
decisions,
Yeah, yeah.
money just felt like money. I
Yeah.
don't think we understood
Yeah.
how expensive everything was going to be.
Yes.
And now with the student loan forgiveness being
Mhm.
in flux, I think it's going to cause even bigger issues for people entering
Yeah.
medicine. Shala and I, in one of our episodes, talked about the high barrier to entry, right? So people who can afford to go to higher education will go. And that means that we will have less representation from lower income households, disenfranchised populations, minorities, and it's going to be a rise of APPs. Unfortunately, if there's not a lot of people going into medicine, we're going to start seeing a lot of APPs. Wendell, do you work with APPs at all? And if so, what's been your experience?
Sure. So I certainly do. I currently work with APPs, and so far my experience, it's been very good. And I'll explain what I mean. And I think I'll also speak quickly, after that, the broader um, sort of scope of APPs and the health model, the teamwork model, advanced practitioners, and personally, I feel that one, the PAVPs I've worked with are very, they are very compassionate, very skillful at what they do. I do believe and I feel that they provide a lot of help when needed and in important areas. And I also believe it's when there's a shortage that the APPs certainly fill an important role. What I do also believe or know is that there's a big difference in terms of the length and the depth of training between APPs and physicians. Uh, Physicians, on average, spend at least 10 years or more in training, whereas the average APP is roughly 2 years or so. So this needs to also be taken into account so that when someone just graduates from their schooling in APP, the knowledge, the experience, as well as not just experience, but in terms of experience with complex cases, it certainly is not to the level of someone who has done 10 plus years of very in-depth training. Earlier we talked about doing being on call for 24 or 30 hours, right? 24 hours you present cases and you still round on your patients the following morning. I believe that it's challenging to find a substitute, a reasonable substitute, especially just outside of training, when you compare the number of years, the number of cases and patients, and the breadth of cases that are seen. So I feel a collaborative model tends to be is one that would be optimal, so that when someone who has, whether it's nurse practitioner, physician assistant, uh, certain bread and butter cases may be, reasonable, but then there are a lot more complex issues which may require a collaborative approach with a physician, or someone who may have had a lot more experience in this particular area. There are some nurse practitioners who've been doing a particular subspecialty or practicing within that subspecialty at very high volume centers for many years, decades plus, and that's reasonable to assume that they would have a similar experience and knowledge of this particular uh, type of cases than someone who just got out of training. So my opinion in general is that a collaborative approach is something that would be ideal, and but more importantly, that everyone understands the scope of their training and their knowledge and where that is. Certainly that would evolve for any person, whether it's a physician, an APP, that certainly would evolve as time goes on. And the more experience, experience they get, the more cases they see after many years, and how much ever work they put in. And through CMEs, collaborating with the specialist, the physician specialist that they work with. But especially out of training, I think it is important that everyone is aware of their limitations and their scope of practice.
Yeah, that's great. I think we are all on the same page. So, what do you think about? There are more than 25 states that is granting full autonomy and independent practice to APPs. Santoshi and I talked about this, that we don't think that that is appropriate, especially if they don't have the experience. At least maybe there should be a requirement of, for example, 2 years in primary care or some sort of requirement before practicing in specialties. For example, in neurology, I mean, neurology is a challenging specialty, requires many patient experiences and cases to be seen, to be able to understand what's going on with complex patients. So I'm not sure, sometimes I think about this, and how can an APP handle a case like this, for example, without having seen one?
Right. Yeah, no, I definitely agree with you, because even as I mentioned earlier, I had 6 years just after medical school. I mean, 4 years of medical school, as we all know. First 2 years are primarily just studying and getting that book work in. But then the other 2 years are just clinical, like working through different specialties, our rotations, getting as much experience as we can. But it doesn't stop there. For us, we did an additional 4 years, right? For neurology, 1 year has to be what we call a transition year, or some year that's very broad, like internal medicine. Essentially, a year of a residency in internal medicine. Then going on to 3 years of neurology. I can't imagine if I were, and then did the additional 2 years of fellowship, right? Each one of us on this call has done another year of fellowship, at least. And I was still nervous just practicing on my own. I cannot imagine, and this has nothing to do with intelligence, okay? Nothing to do with I'm smart, physicians are smarter than this group of other people. It has nothing to do with that. I'm talking about years of experience and the breadth of clinical cases. I cannot see a reasonable substitute for that, okay? So if someone, I know in many programs, the doctorate or maybe entirely, online, or maybe entirely a paper or something like that. And so I think it could be quite damaging coming from someone who does not have the experience to going to doing something, a specialty, on his or her own. So I do believe if this is to pass, or and I know in many places they do APPs practice on their own. It is critical that they know their limitations and their scope of practice. And it may require them to do some additional training, and I don't know how that will happen, but it is really important. I think telling people that they can go straight out, especially on their own, and not collaborating. I mean, that's even scarier. Not collaborating. I just, speaking for myself and most people that I know, even after 6 years of training, we're still nervous the very first, especially the first year outside of training, even with the number of cases that we saw. So I think it can be problematic when someone isn't aware of their
We're going to
limitations.
pause here for this week, but don't go too far. We'll be back for part 2 next week, and we'll tune into the rest of the conversation. Thank you.